I'd like to talk to you about informed consent and informed refusal in the elderly patient. Elderly patients have multiple problems. They take several medications. They have challenging care. They have diagnostic and follow-up problems. They are prone to falls, aspiration, malnutrition, dehydration, and skin tears. And they suffer more adverse drug interactions, and they are subject to abuse and neglect. When treating elder patients, the physician should first determine whether the patient understands the risks and benefits and alternatives to those treatments recommended and the consequences of refusing treatment. Then one would proceed with treatment discussions or recommendations. The patient's mental capacity should be tracked over time with repeat annual mental testing. Often, a psychiatrist may need to evaluate and perform a mini-mental examination, but that may not be required. Simple mental capacity tests include, first, the standard geriatric drawing test. Here, the patient is asked to draw a clock with hour and minutes to indicate a specific time. A second test is the Make a Dollar test. The patient is given 3 quarters, 3 dimes, and 3 nickels, and is asked to make $1. A third test is 3-in-1 2 minutes test. This test involves naming 3 unrelated objects, then asking the patient to repeat right away, repeat them 1 minute later, and again 2 minutes later. A fourth test is the fact test. This involves asking the patient to name 5 of each of the following: fruits, animals, cities in a state, and things that can be purchased in a store. A perfect score is 20 out of 20. The test is objective. It may track a patient's mental status over time. It can be shown to the patient's family members, alerting them to cognitive deterioration. And the data is transferable from one physician to another. Communication is a key risk management measure when caring to seniors who require extra care, elders with problems with their cognitive function or significant hearing loss should be encouraged to bring a family member, a representative, or a friend to the doctor's office. Advising elder patients is difficult for some physicians, but it may be necessary in patients with dementia. A physician may be held liable for injuries to the patient and others involved in an auto accident if it can be established that the doctor knew that the patient had a condition that made driving difficult. Seniors often take multiple medications, which may cause adverse drug reactions and accidental overdose. Elder mistreatment may be physical, such as assault or forced sexual contact or medications, and physical restraints. It may be psychological or emotional. For example, a problem with denial of human needs, such as withholding indicating medical care and fluids. It may be deprivation of civil rights, such as freedom of movement or freedom of communication. Financial exploitation is another problem. and that is neglect. Self-neglect may be suspected in a patient who is dehydrated or malnourished, or someone with ulcers on the skin, poor hygiene, or lack of compliance with recommendations and treatment. Resident mistreatment in long-term institutions may include restrictions of involuntary mechanical restraints. This is condemned by federal regulation and by state institutional statutes and by common law standards. The doctor has a duty to report the neglect to adult services. Indeed, not reporting the suspicion may cause the physician legal problems, including possible loss of his or her license. State law protects the physician from civil or criminal liability if he or she reports suspected mistreatment, as long as the reporting is done in good faith. Over-reporting is preferable to under-reporting. If an elderly patient is associated with a healthcare provider's negligence in some way, such as alleged failure to follow up or order hospitalization when it is appropriate regarding symptoms, say, of malnutrition or dehydration in an extended facility, or failure to report abuse, the provider can be the target of elder abuse lawsuits in some states. And a cap on non-economic damage awards does not apply. Malpractice lawsuits hinge on whether the physician did everything that he could for the patient. Any competent adult can refuse treatment or intervention. If the doctor is concerned that a patient does not have the mental capacity to make such a decision, and the patient has not given anyone legal authority to be a proxy or by power of attorney to make the medical decisions on behalf of that patient, it behooves the doctor to ask a legal counsel or insurance company risk manager how to proceed. The patient's next of kin does not automatically have authority to consent to or refuse treatment. And finally, the physician who orders a surgical procedure, aggressive treatment, or high-risk medication for an elderly patient should obtain and document the informed consent from the patient or the designated representative. Thank you.